and good to be back at York with your kind of leading these kinds of conversation with students, and really wanting to use a bit of my time to just talk about the place and the role of advocacy. And every time I talk about advocacy, and health advocacy specifically, is wanting to contextualize it for you within the context of the work that has been done by Margaret Whitehead, World Health Organization, and many of you know her as the ambassador, the mother of the language and research around health equity, health inequality. And one of the things that she talks about when she says, when we ask the question, what do we mean by when we say health inequalities? And she says, differences in health that are unnecessary, avoidable, unfair, and unjust. So I begin with that as a frame for when we begin to think about what this policy and the cuts to Interim Federal Health Fund means for the communities of folks we're talking about. And also begin with that quote in the context of yourselves as students, as academicians, and or as workers who are involved in social justice issues, for us to ask ourselves that in the various roles we have, what is our place in that definition in responding to the unfair, the unequal, and the unjust. And I want to position that our role is really to be agents of change. That many of us come to these institutions, and for some of us who are new immigrants, our parents sent us to these places to get a position that we could have what we need for health and well-being. And it wasn't necessarily always tied to notions of social justice and social change, but I want to position to you that wherever you go from your work in the academy is that one of the underpinning of how you need to see your role is as agents of change. Because if we cannot accept the fact that inequalities exist and not also assign ourselves some responsibility for responding to changing the conditions around social inequality. So, wanting to frame that for you as well as a piece of conversation. The conversations and what Meb and Manavi have talked about around the cuts to Interim Federal Health Fund, I think has come from a number of places. So one, you have a political government, you have a government that has some political platforms and some policies that are really fueled by xenophobia, that is fueled by, and this particular policy, by an anti-immigrant sentiment. We have seen echoes of these kinds of policies previously in times of scarce resource, in times of depression and or recession, where you turn to the folks who are different from who you are, or you create notions of difference to say that those people are taking away these scarce resources from those of us who are entitled to this thing, who have a right to this thing. And this thing that we're talking about is healthcare in this particular context. I think also what we have seen in this particular political context where the cuts have emerged is notions and the linking of notions around the right to access to care being linked to notions of citizenship. And I would also say that we have also seen similar arguments around rights in times of quote-unquote scarcity, and we're talking about austerity being the new language, is that there is a positioning that the people who are entitled to the things that are available and should be available for equity, for fairness, for health and well-being, somehow immediately gets tied to notions of entitlement around citizenship. And I think part of the advocacy efforts here is to delink notions of right to health care from notions of citizenship. Is that health care, one would say, I would say, many of you in this room would say, is that health care is a human right. And folks say this is a lofty principle that we can't really live by because, Angela, we're grounded in economics and we can't pay for everything for everybody. But suddenly you ask the question, and I think the answer that's suggested is that we need to now parcel out healthcare as a commodity. And I think part of the challenge in this is that many of us are saying from a health advocacy standpoint that this is not a commodity, that this is an essential requirement for daily living and that people should have rights to it and that it shouldn't be tied to notions of citizenship. The other, I think, perspective around health advocacy in this particular issue is that the issue of health care and access for immigrants cannot be delinked from issues of immigration, questions of immigration, that it cannot be delinked from issues of nation and national relationships and who become legitimate nation states and partners. So when we talk about the DCO list, it's about who are the countries that we will deem to be quote-unquote safe countries. And many of us would ask the national policy question about what gives Canada and Jason Kenney any kind of perspective on who becomes a safe country based on Jason Kenney's analysis. And we could question the limitedness of that and all kinds of things. But from a national perspective, from a policy perspective, we also need to think about how places of the North also then begin to define what becomes safe places and unsafe places from the South and elsewhere. So I kind of paint that picture then to suggest that in this issue and on this issue, we need to do what many of, in the academy we talk intersectional analysis, is that we need to do collaboration building, we need to do collaboration struggles in linking with other struggles so that really we're not doing a standalone and we're not falling into really what the government would want, which is a segmenting of the issue. We're saying the issues are very much interrelated. Issues of immigration, issues of nationhood, issues of citizenship, and issues of entitlement to health care. So MEB has identified that when this policy was announced in April, there was swift mobilization on the part of clinicians. On this particular issue, I would say that what made it particularly successful in that early start was the leadership of clinicians and particularly the leadership of physicians. Because physicians have not been known institutionally as being the collective radical group. So when this group of clinicians spoke to this particular issue, it resonated with the quote-unquote the public, because we were just also on the cusp of the Occupy Toronto movements, and I would say we're still in it, some people would debate, but I would say that the Occupy movement inspired the clinicians to take those kinds of strategies on this particular issue. So when we're thinking about health advocacy on these issues, is I think a few variables for us to think about. So one is about the credibility of our leadership. Two is about having some particular champions, whether it be positional champions and or individual champions, for whom credibility resonates with the public. Particularly on this issue, when there has been an attempt to divide based on the anti-immigrant sentiment of the government. Three was also the strategy of having it be a national struggle. So it wasn't localized as the government would want to be just in Ontario, where you have the most immigrants and refugees. So this was a national advocacy campaign that spread across the country. So when you think about advocacy and health advocacy, is also to think about beyond your local boundaries. As well, a variety of actions. Some of us love demos. I love a demo. And we need visibility on the street. Also layered in the health advocacy in relation to this particular issue was the policy table advocacy. So you had many folks who were doing the public demonstrations, doing the sitting and the occupation of ministers' offices, doing the impromptu interruptions of ministers' press conferences by getting up and asking the question at the Minister of Sports, who is opening some new facility, but asking her or him about refugee health cuts and what the government was doing. So we had those kinds of advocacy as well. When you think about health advocacy and all of those variety of strategies, you also need to recognize the element of risk. And the element of risk with a government that is also punitive. So one, you had some particular targeting of Mark Tyndall. So this was a physician who first came out and who was named and targeted by the minister, just by virtue of the minister naming this particular physician as Dr. Tyndall is saying, basically Dr. Tyndall should stick to serving patients and stop the advocacy and stop commenting on public policy. So you need to understand that there is an element of risk in doing advocacy for social change, but I would suggest that the risk is worth taking. Also that, and MEB identified that you had over 20 national organizations who were association bodies. So if as an individual your role is about social change, then if you are linked with an association, you also need to push your association to be accountable for responding to that social change agenda for you and or within the profession that you sit. And that is what happened when we saw the number of signatories on the part of national organization, and York was one of the organizations with Michaela's work in terms of the York Institute for Health Policy, who wrote a response to the minister and a public statement response objecting to the cuts. Lastly, I will just end off by saying that there are a number of organizations that, if you are interested in connecting from a health advocacy perspective on this work, you have the organization called Health for All, a number of clinicians, social service workers, community workers who have put together a group, and the email address www.health, the number 4 all.ca, and you can connect with me at the end. We have another group called the Right to Healthcare Coalition, and the group that we have here at Women's College Hospital, the Women's College Network for Uninsured Clients, and I see familiar faces in the room who've attended some of those meetings. Just ending on future actions for advocacy and some opportunities for your involvement and or for some work that you can take away from here into your classrooms and or into your community spaces, is we have a DCO, Safe Countries list, that the government has identified that it will be releasing shortly. Many of us have taken the position that there should be no creation of such a list. And we're really suggesting that here is an opportunity to do some broad mobilization, telling the government that there is no such thing as a safe country, and that there are unsafe conditions in every country, and as a result there should be no production of a DCO list. The other, I think, piece is for you to also connect with your local communities. So you are in neighborhoods where you have an MP, you have an MPP. If you have an MPP, it's the province, and it's really wanting to push the province to take a position to say that it will fill the gap, as Manitoba did, as Quebec did, that it will fill the gap created by the cuts to interim federal health. So not that it will stop advocating with the federal government, but that it will fill the gap while we struggle with the federal government to reinstate coverage. So that's another advocacy effort. And then lastly, it is connecting with your MPs, so where you have a federal sitting representative, is to take the cases to the MP's office. Because one of the things that is most effective in doing advocacy is having the individuals who are most impacted have the ability to give voice to their experience and or to give voice to the impact that they will experience based on the inequality of cuts that are about to be made that will impact their condition. So those are just some ideas to think about and to maybe spark some conversation as we have the open dialogue. Thank you.